Welcome to the deep dive. Today we're getting into something really critical, but often kind of hidden, the stages of medical shock.
That's right.
Our mission here is to unpack how the body reacts under extreme stress and maybe highlight why catching those subtle early clues is just so vital. It's about giving you the shortcut to understanding a condition where time is everything.
Exactly. And when people hear shock, they often picture something really dramatic, like you see in the movies.
Right, a sudden collapse.
Yeah, but the really crucial stuff often happens much earlier in stages that aren't nearly so obvious. We want to connect those internal body signals to the outward signs.
Okay, so let's unpack this then. Shock isn't just one thing, it's a process, a continuum.
Definitely.
Our sources break it down into three main stages: compensatory, progressive, and then irreversible. And the compensatory stage, that first one, that's where it gets really interesting because the body's fighting like mad, often totally under the radar.
That's spot on. In that compensatory phase, physiologically, what's happening is the body's basically hitting the fight or flight alarm. Big time.
Ah, the sympathetic nervous system response.
Right, you get this flood of catecholamines and adrenaline, noradrenaline, and the body gets really smart really fast. It starts prioritizing
Prioritizing the important bit.
the vital bits, brain, heart, lungs, got to keep those going. So it starts shunting blood away from places like your skin, your kidneys, even your gut.
Wow. Okay, so it's like an internal triage, even while maybe the person seems okay on the surface.
That's the deceptive part. The body's already in crisis mode, working incredibly hard, but the blood pressure, it might still read normal.
That seems dangerous. So if the blood pressure is holding steady, what are the signs? What should we be looking for in this compensatory stage?
Good question.
Mhm.
Because the blood is being redirected, you might notice the skin feels cool, maybe looks pale.
Makes sense. Less blood flow there.
Exactly. And because the gut isn't a priority, bowel sounds might get really quiet, hypoactive. Urine output drops too. That's the body trying to hold on to every bit of fluid, releasing hormones like aldosterone and ADH.
Okay, holding on to fluid. What else is happening inside?
Well, metabolically, things are shifting. Cells aren't getting enough oxygen, so they switch to anaerobic metabolism.
without oxygen.
Right. And the byproduct of that is lactic acid. It starts to build up, leading towards metabolic acidosis.
Acidosis. That sounds bad. And the body tries to counter that.
It does. You'll often see the respiratory rate climb. The
Why?
person starts breathing faster, deeper,
Wow.
trying to blow off carbon dioxide to, compensate for the acid building up. Sometimes they breathe so fast they actually cause a temporary respiratory alkalosis.
So overcompensating almost.
In a way, yes. And another really key thing, look for changes in mentation,
Mm.
confusion, maybe agitation, or just they're not quite themselves. Subtle shifts.
Okay. So cool skin, low urine, maybe faster breathing, a bit confused, even with normal blood pressure.
Exactly. And crucial point is, if you start treatment now, in this stage, the chances of a good outcome are much, much better.
But that leads to the big question, doesn't it? If the BP is normal, how do doctors or nurses catch it? It sounds like a really narrow window.
It is a narrow window.
Yeah, our sources really emphasize this, especially for septic shock. Getting aggressive therapy going within 3 hours of spotting it
Yep.
makes a huge difference in survival.
Absolutely critical. And that's why healthcare teams, especially nurses who are often at the bedside constantly, are trained to hunt for these subtle clues before the blood pressure tanks.
So what are they looking for specifically, beyond what we just mentioned?
They're watching the level of consciousness very closely, any dip, monitoring all vital signs meticulously, of course.
Mm,
Tracking urine output, is it less than that 0.5 milliliter per kilogram per hour mark?
okay.
Checking the skin again, how fast does the color return after pressing? Capillary refill, is it sluggish? Is there mottling? Little pinpoint spots called petechiae.
All signs of poor perfusion.
Right, and keeping an eye on that respiratory rate. Plus, if they suspect infection, getting blood cultures is key before starting antibiotics. You might also see things like elevated sodium or blood glucose on lab tests early on.
Okay, here's something our sources mentioned as a practical early clue. Pulse pressure. What's that about?
Ah, yes, pulse pressure. It's simple to calculate, just systolic pressure minus diastolic pressure.
Like 120 over 80, the pulse pressure is 40.
Exactly. And normally it's somewhere in that 30 to 40 millimeter Hg range.
So what happens in early shock?
This is fascinating. You often see a narrowing or decreased pulse pressure. So maybe the blood pressure is 90 over 70. The pulse pressure is only 20.
And that's an earlier sign than the systolic dropping.
Often, yes. It signals that the stroke volumes, the amount of blood pumped with each heartbeat, is decreasing. The body tries to compensate by clamping down blood vessels, which actually raises the diastolic pressure for a bit.
So the body's attempt to help.
Gives us that early warning. The narrowing pulse pressure tells us vasoconstriction is happening, that the system is stressed even before the main systolic number falls off the cliff.
That's a really key insight. So we've got clinical signs, basic vitals, pulse pressure. Are there more advanced ways to see how well tissues are actually getting oxygen?
There are. For instance, central venous oximetry, or CELS-2. A special catheter measures the oxygen left in the blood returning to the heart.
So it shows how much oxygen the tissues actually use.
Precisely. A normal SpO2 is around 70%. If it's lower, it means tissues are extracting more oxygen because delivery isn't keeping up. It's a sign of that hypoperfusion we talked about.
Okay. What else?
There's a relatively simple bedside test called passive leg raising, or PLR.
Just lifting the legs.
Pretty much. You raise the patient's legs 30, 45 degrees. It shifts blood from the legs back to the heart. If their blood pressure or cardiac output improves significantly...
But need more fluids.
Right. This suggests they're fluid responsive. If there's no real change, giving more IV fluids might actually be harmful, potentially causing fluid overload.
That's clever. Simple but effective.
It is. And for patients on ventilators, we now use more dynamic, functional hemodynamic monitoring methods that give a better real-time picture of fluid status than older static measures like just looking at central venous pressure, the CVP.
So once you've identified shock is happening, even in these early stages, what's the game plan? What are the interventions?
Two main goals, really. First, decrease the body's demand for oxygen.
How?
Things like sedation, managing pain effectively, controlling fever, maybe even mechanical ventilation to reduce the work of breathing.
Okay, reduce demand.
And the second goal.
Increase oxygen delivery. That means supplemental oxygen, maybe more IV fluid if they're fluid responsive based on things like PLR, medications to support blood pressure and heart function, and sometimes transfusions of packed red blood cells if hemoglobin is low. Makes sense. Decrease the need, increase the supply. Now, we've been talking generally, but our sources flagged something important. Recognizing shock in older adults can be a bit tricky. Why is that?
That's a really crucial point. Older adults often have underlying chronic conditions, and just the physiological changes of aging make detecting shock much harder. Their bodies don't always react in the textbook way.
How so? What gets masked?
Well, for example, many older adults are on beta blockers for high blood pressure or heart issues.
Right.
Beta blockers slow the heart rate. So that classic sign of shock tachycardia, a fast heart rate, might be completely absent.
Oh, wow. That takes away a major warning sign.
A huge one. Also, their immune systems might not be as robust. So even with a serious infection causing septic shock, they might not develop a high fever.
No fever.
Or maybe just a slight temperature increase, or even a temperature below normal, like less than 37 Celsius. You have to look for other signs like new fatigue or malaise.
So you can't rely on fever either. What else?
Well, if they become hypoxic, low on oxygen, it can cause heart rhythm problems, arrhythmias. But those might get brushed off as just related to their age or existing heart conditions, not seen as an acute sign of shock. And their lungs often have less reserve capacity. They can decompensate, go downhill much faster if their breathing is stressed.
And you mentioned mental changes earlier.
Yes, and this is critical in older adults. A sudden change in mental status confusion. Delirium is often mistakenly attributed to dementia or just old age. Instead of being recognized as the potential sign of infection or poor organ perfusion due to shock, you have to aggressively assess for acute delirium and consider shock as a cause. Look for any change from their baseline.
It sounds like you need a very high index of suspicion with older patients.
You absolutely do. Vigilance is key.
So moving beyond the pure medical mechanics, this is obviously a huge crisis for the patient and their family. What about the human side of care during shock?
Immensely important. Patients are often terrified. Families are anxious. Simple things make a huge difference.
Like what?
Providing brief, clear explanations. Even if the patient seems confused, talk to them. Support them during procedures. Share updates, even small ones. Using a calm voice, a gentle touch, it can be incredibly reassuring.
And for the families?
They need honesty and consistency. Regular updates, even if the news isn't changing much. They need to feel supported emotionally and physically. They need to know the plan, who to talk to, and feel that their loved one is being watched closely.
Does having family there help?
Often, yes. Advocating for family presence when appropriate and involving them in discussions and decisions can really help communication and reduce everyone's anxiety.
That makes sense. Now, another sensitive point our source raised, given how fast shock can change things, advanced directives, why is sorting that out so important here?
Because things can deteriorate so rapidly. It's crucial to ask patients, ideally on admission before a crisis hits, if they have things like a durable power of attorney for healthcare.
Designating someone to make decisions if they can't.
Exactly. Or a living will, outlining their treatment wishes. Or maybe a PAPOL form, physician orders for life-sustaining treatment, which are actual medical orders.
So you know what they want.
Yes. If their condition worsens suddenly and they can't communicate, having those documents clarified ensures their wishes are respected. It's about honoring their autonomy.
A difficult conversation, but a necessary one.
Very necessary.
And just briefly, patient safety. With altered mental status, lines, tubes.
It's a constant focus. Patients who are confused or anxious might pull at IV lines, oxygen masks, catheters. So close observation, frequent reorientation back to where they are, using bed alarms if needed, fall precautions, all essential to keep them safe while they're so vulnerable.
This has been incredibly insightful. It really drives home that shock isn't always this sudden, dramatic event. It's often this sneaky, progressive state.
It is.
And understanding those subtle early signs, the body's amazing, but limited compensatory fight. It really gives you a new perspective, doesn't it?
It absolutely does. And maybe the final thought is, recognizing these hidden signs isn't just a medical skill. It's about appreciating how fragile and yet how incredibly resilient our bodies are. And it highlights why being observant, being proactive in care is just so fundamental. So maybe the question for you listening is, how does understanding this intricate internal battle change how you think about health, about vulnerability, maybe even about the quiet struggles happening inside all of us?